Hi, today I would be talking on one of the important disease conditions in our practice, urticaria and its management, and specifically chronic urticaria, which is likely to affect up to 20% of the population during their lifetime. Commonly presenting with pruritic wheal and flare reaction, which may be associated with angioedema, urticaria can also cause pain for some patients. Factors triggering the onset of urticaria can be identified in some, but the disease is idiopathic in up to 50 to 80% of all cases. Through this understanding, our best option to manage this condition is to avoid identifiable triggers, but mainly to counter the allergic pathophysiology of urticaria using antihistamines. While all international guidelines recommend non-sedating second-generation antihistamines as first line of treatment for urticaria, it is difficult to select the ideal one as the commonly prescribed ones lack efficacy, for which we need to add or updose currently available antihistamines according to patient profiles. Today, I would be talking on belastine, which is a new second-generation H1 antihistamine with ideal characteristics that has recently been launched in India. Belastine has been approved in more than 100 countries globally, with large and extensive clinical data studies conducted on more than 5,000 individuals and more than 22 million patients using belastine worldwide. It is considered as the first choice antihistamine amongst Asian Pacific physicians. ARIA recommends belastine as the highest scoring antihistamine amongst all other second-generation antihistamine, and it is the only one to achieve a perfect 10 in the antihistamine scorecard. In India, it has recently been approved for the symptomatic treatment of allergic rhinitis and chronic urticaria in patients older than 12 years of age. The APAC review on the selection of optimal second-generation antihistamines for urticaria in Asia has also given its support to belastine's safety. Belastine's robust clinical assays and studies in healthy volunteers and the accumulated clinical experience show that it has a profile of adverse events similar to that of placebo and does not appear to significantly influence cardiac conduction, alertness, or driving ability, even in doses up to 40 mg. Belastine does not prolong the QT interval and does not cause significant changes in the ECG at therapeutic and even supratherapeutic doses, making it an ideal choice with regard to cardiac safety concerns. Considering belastine pharmacokinetic profile, it does not have any CYP450 mediated drug-drug interactions. It is also not necessary to make dose adjustments in patients over 65 years or in patients with renal or hepatic impairment. Low potential for CNS impairment when co-administered with alcohol and other CNS depressants is another advantage. At therapeutic doses, belastine does not have anticholinergic effects and does not affect psychomotor performance. It also has a limited passage across the blood-brain barrier due to its good substrate for PGP. As it shows relatively zero brain H1 receptor occupancy compared to others, the incidence of sedation with belastine is similar to placebo, even in dosage 4 times the approved one. As a clinician, I would look forward to use belastine as it checks most of the boxes for the qualities needed with regard to safety of an antihistamine. Belastine has been acknowledged for use by guidelines such as ARIA as the only one to achieve a perfect 10 in the antihistamine scorecard and has also been scrutinized to become the first choice antihistamine amongst Asian Pacific physicians.